The one step back I would take is make sure you rule out medical causes. One case that I have painful familiarity with was somebody who was older than this, was a known abuser of pharmaceuticals, including temazepam, is found down in their home, has a bottle of temazepam next to them, brought into the ER. They just say it's a temazepam overdose. Intubate them, send them up to the ICU. When they did the head CT 2 days later, because the patient didn't work up, the blood in this lady's skull had layered out, so all the red blood cells were down below and all the serum was up above. So they missed a bleed into the head. That easily probably had a better chance of having a better outcome if they had done the scan 2 days before.
All right, I'm Prashant Joshi from Buffalo. Before I comment, I actually came up with some survival strategies for myself to hide my lack of knowledge. And one is mumble. 2 is hide behind computer. 3 was say a lot and have people comment on the quaint Canadian up on the panel. Pretend to have a cough and drink some water, and if all else fails, defer to Ed Bottet at the end of the table. So. But I'm going to take a crack at this. So I agree with what's been said by everybody. For me, there are a couple of things that come out. One is that this is not typical for benzos or for the newer benzodiazepine receptor agonists. This is more reminiscent, if it's a sedative at all, more reminiscent of phenobarb, barbiturate, chloral hydrate, those type of old-time, what they call non-barbiturate sedative hypnotics are more likely to cause bradycardia and hypotension. We certainly see this in the ICU when we have people in pentobarb coma for head injury and status epilepticus. And the other things is non-sedatives. Again, I think of a mixed ingestion. Verapamil, for example, will cause bradycardia and hypotension, although it usually shouldn't cause altered mentation unless the patient's in shock and it's not perfusing his brain. Beta blockers definitely come up in the differential. I don't know whether temazepam, Tenormin, they both start with a T. They were mistaken, it's possible, so a tenolol overdose. And I wanted to comment a little bit on the management here, and this is sort of just, you know, as a physician who might be treating these, whenever I see a patient who is bradycardic and hypotensive, if they don't respond to fluids and so forth, it might sometimes be worth a trial of atropine, even if you don't know what's going on, because this is an inappropriate bradycardia. So how much is the bradycardia contributing to what's going on here? So if this is baclofen, for example, can cause this, or even, what was the other one I was thinking of? A clonidine or something, which doesn't respond. They sometimes respond to a dose of atropine. If you get the heart rate up, their blood pressure will improve. That's really all I have to say.
The great thing about being last is I could always say I agree with the panelists ahead of me, but I definitely agree with what's been said, and maybe a different angle on this is seeing what the response was by the SPIs and the directors and other folks that are here. It pretty much follows the protocol that we have at the Poison Center where we work. We don't haphazardly recommend antidotes without consultation. So I'd be surprised if any of our SPIs that work at the Georgia Poison Center went ahead and said, you know, we know what that dose is and we'll go ahead and recommend it. I mean, we have a policy that every antidote that has to be given has to be consulted with by one of the toxicologists. But having said that, it doesn't surprise me that overwhelmingly the response by the specialist here was that of that final choice. But in our differential, I agree, barbiturates, antihypertensives, I mean, there are a number of things that can go on here. I don't know that we are, you know, big time on dose off the top of our head, but I definitely would expect one of our poison specialists to give us a call to make sure that we haven't missed either a bleed or other considerations when it comes to drugs of abuse or other pharmaceuticals.
Okay, we'll carry on. So now we have a few further details. This patient's current medications are phenobarbital, ASA 81 milligrams, omeprazole, temazepam. His past medical history, he does have a seizure disorder. He last seizured 5 years ago, and he has previously overdosed on his phenobarbital 2 years ago. So my question to the expert panel at this point, Would you GI decontaminate? Single dose activated charcoal, multiple dose activated charcoal, whole bowel?
I'll take a stab at that. Right now, with a guy who's obtunded and hypotensive and bradycardic, I don't think I would do any of the above. I think you're asking for trouble doing that. I think the next question that might need to be asked is, does this guy's airway need to be secured? Right. And if that is yes, then you might want to consider going ahead with any or all of those modalities. And I'll let somebody else comment on that part.
I mean, we're looking at a patient with an unknown time of ingestion, and oftentimes if we don't have specific windows where we know when the ingestion occurred, then it's likely that we're going to back off on any GI decontamination recommendations. So, you know, when I first hear that we have no clue as to when the patient might have taken it, I'm probably laying off.
Yeah, I would have to agree also. Better to forego GI decontamination than to kill the patient by sticking, 25 grams of activated charcoal into their lungs. During my fellowship, that actually happened. Non-lethal, probably a non-lethal ingestion. The NG tube goes down the right main stem, followed by 25 grams of activated charcoal. The patient never left the emergency room. So yeah, in this case, I would definitely forego those 3 forms of GI decontamination listed.
I think this is one of the times when, since we have phenobarbiturates being part of the differential, it's easy enough to get a phenobarb level. And at this point, it would just be purely supportive care, atropine and pressors, and support until you get a little better clue as to what's going on. We wouldn't recommend GI decontamination either.
Okay. Well, the toxicologist was consulted with, and the toxicologist was questioning whether the patient's status was due to the phenobarbital. So the recommendations at that time were to intubate the patient, monitor the phenobarbital levels, give multiple dose charcoal, and no role yet at this time for dialysis or urine alkalization. So 5 hours after presentation, the Emerge calls Poison Center. They're having problems maintaining the patient's blood pressure. It's still, the blood pressure is only 60 over palpation. The heart rate is 65 to 75. The patient does have a central line in place. Currently receiving dopamine at 20 mics per minute, Levofed at 20 mics per minute, and phenylephrine at 40 mics per minute. Now the question is it common with these possible ingestions to have hypotension unresponsive to vasopressors, and is there what other treatment options would you consider at this time?
Before going to that, did you have a temperature on this patient at any time?
I don't believe so.
Okay.
That's a good question. I'm trying to think back, and I'm not the one that dropped off the page, whether the patient was hyperthermic or hypothermic, put it that way.
Thank you.
Do we have any other levels? Do we have anything from that?
Well, unfortunately, at this point, this is at a smaller hospital in Ontario, so blood levels have to be sent out. So we're looking to another town or city. So no, we don't have anything at this time.
Yeah, this is, I think, the question, is this usual? I think the answer is no.
Yeah.
That they shouldn't be unresponsive, and I think you really need to really wonder, is there anything else? There are a couple of things I want to think of. First of all, are these drips really going at the rate you think they're going at? Because sometimes people get confused between mics per kilo per minute and mics per minute. You may be giving the wrong dose of something. I've had empty bags of things running before where everybody thought there was something going and it was normal saline. So that's always a possibility. The other thing, the guy has a central line. He's presumably relatively healthy, 45-year-old, doesn't have coronary artery disease or anything.
Just a seizure disorder.
And I think you should be able to get a good idea of his filling volume from his central line. I think you need to make sure his filling pressure, his preload is optimized. He may be volume depleted or something, and he's going to have a limited response to inopressors. I don't think, he needs to be swanned or anything. I don't think there's really any value in looking at his left atrial pressure. One of the things that we have in our arsenal now, though, is bedside ultrasound. And a lot of ICUs are using it, I don't know if Ed is using it, emergency departments. And it might be interesting to take the old wand out and put it on this guy's chest and see if his problem is a problem of cardiac contractility, or if it's not, then it's probably a problem of vascular tone. And that'll give you an idea of at least of which pressors and kind of what things to use, because again, if you're thinking of a calcium channel blocker or a beta blocker, you may want to start with endocrine therapies if he responds to nothing else. And then this is a real zebra, but if the guy is, if he has a past history of being, on hydrosteroids or something, is this guy presenting with an ingestion, but he's also adrenally insufficient, and would he respond to a dose of hydrocortisone or something? You always think about that in ICU in unresponsive shock.
It's BNP too.
In addition to this, I mean, from a history standpoint, as I'm looking at, how am I dealing with this hypertension, refractory, what other treatment options, I would probably want to make sure that our specialist is asking about other family members and their meds that they may be taking. Certainly, if we're just looking at phenobarb and Restoril, and maybe there are truly other medications that either grandparents are on in the house, or a spouse, or a child, and that might give me a better view of what I might need to do in the coming moments.
One of the things I'd really like to do, and it should have really been done probably initially, is get a basic metabolic profile. What's their acid-base status, what are their electrolytes, what's the glucose like? That could point us towards a calcium channel blocker.
Right.
That would be very helpful.
What about a 12-lead?
Please come to the microphone so we can all hear you. Thank you.
Was an EKG performed? Was there a 12-lead to help determine, if we're looking for other substances, to see if there are any prolongations?
I'm sure it was done, I just can't remember it being, it wasn't commented as being abnormal or major irregularities at this point.
When they did multi-dose charcoal, were they checking bowel sounds?
Well, at this point, it was just being recommended.
Okay.
Yeah, at this point.
And there was another question?
It was the same question.
Okay.
I think I'd hesitate to give charcoal without having more information.
Right.
If we don't have a phenobarb level,
Right.
Certainly the last thing you want to do is make things worse. And even if they're intubated, it's no guarantee that they can't vomit and aspirate.
Right.
But the easy stuff is what I would like to see is, a real good metabolic profile, and the smallest hospital can do that.
Right.
I have a question for the expert panelist. If we did have an elevated phenobarb level, would y'all recommend the multi-dose charcoal?
Well, from my perspective, it depends on how high it is.
Okay.
If you're talking a level of 40 or 50, probably not. If you're talking a level of 120, probably. And I'd also be thinking about urinary alkalinization at the same point. The one problem that I have is as you get closer to therapeutic range, you keep giving the multi-dose activated charcoal, you absorb too much phenobarb, and the person's seizure disorder kicks back in, which probably isn't going to be that much of a help to them in the ICU.
Thank you.
The other thing real quick, Dr. Dart just put out a paper recently, that we're not giving enough charcoal, what I'm saying, entirely not enough. It should, and regardless if people agree with it or disagree. But so the question to you guys is that in these type of cases like this, is it truly going to be a benefit to use multi-dose charcoal or charcoal at all, even in the event that it might not even be helpful, because we only give 1 gram per kilo, and it might not be enough. And then what would be the subsequent dosing that you guys recommend for the second, the subsequent dosing of charcoal? Do you do another gram per kilo, or do you do half, and at what time?
I agree with what Ed said, and I'd like to add, I'm not a big proponent or a big user, if you will, of multiple dose activated charcoal. I personally think it's overdone. You want to, again, I think it's very level dependent here. If I do recommend it, it's usually 100 grams to start and then 50 grams every 2 to 4 hours. But the thing is, this is an intubated guy in an ICU. He can't stand up and go and sit on the commode and, excrete his charcoal. So if the nurses were your friends before this patient, they will not be your friends after this patient. So I think you really, really want to make sure that what you're going to do is going to help the patient. There are a lot of patients, for example, who we give antidotes after they're already supported in an ICU, and I would argue that if you shorten his period of intubation by 4 hours, it's not really a big benefit. If somebody's intubated for 48 hours or 55 hours, the big risk in an intubation, for example, is the intubation, where you might lose his airway, and the extubation, where someone can get laryngospasm or something. Once they're sort of safely protected and maybe sedated, and again, assuming that his blood pressure comes under control, I think you probably don't need to. The other thing is, if you've got a hypotensive patient who may not be perfusing his gut very well, I don't know how much I'd want to be sticking stuff down there and risking giving him an ischemic gut on top of everything else. Ed, do you see
No,
anything
all those points make a great deal of sense, and I agree with all of them. If it were a difference between extubating 24 hours earlier versus 4 hours earlier, then it would be different. But if you're only going to save 4 hours of extubation time, that's probably not going to be all that beneficial. And you're right, I wouldn't be necessarily looking so much at dealing with the phenobarb as the ABC, starting with good supportive care. Because as already mentioned, there aren't, with the issue of antidotes, there aren't a lot of antidotes that we give. And even in those that we do give, it's still good supportive care. The airway, breathing, and circulation first and foremost. And the circulation is still the problem because this person's still hypotensive on at least decent doses, apparently, of 3 adrenergic vasopressors. So I'd actually be traveling down that pathway before I'd be traveling down what to do about this possible phenobarb that we don't even have a level for. So I wouldn't give multi-dose activated charcoal, because what happens if it turns out it's not phenobarb? You are now giving a treatment for a diagnosis that doesn't exist.
So we do now have some initial blood work, as you can see, in both SI and traditional units. Liver functions, unfortunately, were not available at this time, but the patient does have a note of all the blood work. Detectable acetaminophen level, 105 micromoles per liter, or 16 micrograms per milliliter.
So what is the...
So my next question is, now the patient has a detectable acetaminophen level. Unfortunately, we don't have liver functions. Would you recommend Mucimus for this patient?
These questions come up all the time, and they're, honestly, sometimes when, the SPIs will call me and ask me this question, my first response is, well, how the heck should I know? You're asking me. You have to look at, the first thing I always do is, even when they're unknown, I'll take the plot, I'll take the Rumac-Matthew nomogram and plot it and say, okay, you know what, how far out would it have to be toxic?
Right.
And if it's beyond 24 hours and the LFTs are normal, then there's no point.
We just don't know yet.
Yeah, the other thing that you have to look at is, if you've taken some drug that causes hypotension and bradycardia and so forth, you got to look at the time course of other co-ingestants. And if you've got a drug that, if it had been 24 hours since it elapsed, the guy would have died at home, and that's the only time it would maybe be toxic, like 18 or 20 hours, I would be less inclined to give it. I think a number of things have to be considered. So I don't really have an answer to this one specifically. I think I'd need more information.
Right.
Maybe talk to the family or somebody.
Right. Just fair.
With about 12 toxicologists on staff, at our poison center, we'll definitely have 12 different answers here. There's just no question. And as we're talking about, this is more common than some of us may even want to care to admit to. And it's definitely going to be a judgment call on a case-by-case basis, but I know on a given day where I might have 4 other colleagues in the office, I wouldn't be surprised if all 4 of us had different answers. And I might do a little back plotting. I might be thinking, safe than sorry. I don't have LFTs. What am I going to do? And this is always a minute-by-minute decision. So in a case like this, if you were pressing me and I probably know what our SPIs would say an unknown time, a level of 16, I'd probably say 95% of our SPIs would say we should give this person NAC. And obviously that's why they come to us to get that confirmed. But again, I don't know that there is a right answer for this. If I maybe had just finished reading a NAC article, I probably right then and there might say, okay, let's give NAC. But I don't know that I would say that that would be my #1 answer.
Yeah, I agree with what has been said already. Definitely want more information. If a gun were put to my head and this is all the information I have and all the information I'm ever going to have, then yeah, I would say treat. But I would do the back plotting. This level's a little under 17 hours on the rheumatic Matthew nomogram line. So I'd say, you know, what from that time has the patient been seen in the past 17 hours? What's been going on? Does anybody have any clue by way of the family? So get that information, get the LFTs, and then make a decision.
Yeah, I do agree with everyone, the other panel members. This is really, it is always a tough call, and I think I tend to be a little more conservative, thinking in terms of we have a detectable APAP level, unknown amount of time. I'd want to get more, obviously a better history. When was the last time she was seen? Has she been down, not seen for 24 hours or so? We should be able to get a CPK. She'd been down for a long time. We're going to definitely see a rise on the CPK. And I think I would probably be more inclined to treat, given what we have now. This is all we have. It's a fairly benign treatment if it's administered properly, and expensive, but if we finally get the LFTs back and they're already in the thousands, I'll be glad that we did.
My question to the panel is, these are really common cases where you see a town hall level and really no history, and oftentimes you just don't get a history. Do you see any downside to giving it? Because I know at our poison center it's always just give it. It's not going to be, the guy's not going anywhere for the next 21 hours anyway. I mean, is there really ever a downside to giving it if it's administered properly?
Well, if the guy's allergic to N-acetylcysteine and dies, I suppose there's a downside. I'm not talking about the anaphylactoid stuff. I'm talking about rare instances of true allergy. I know that's unusual. What you may want to consider doing, if the guy's gut can tolerate it, just give it orally. Yeah. Rather than giving an IV. Just stick it down with an NG tube. Probably safer.
Okay. And that's what I was going to ask, is do a short course mucomyst PO, repeating the LFTs in 24 hours, because we wouldn't repeat the Tylenol level, but by then we should also know we would be erring on the side of caution, giving them a relatively safe antidote, unless it'll obviously upset the ICU staff because of the smell and stuff. But I think in our protocols and the way we approach it with Dr. Lopez is to err on the side of caution in these events, because but we're going to wait for these LFTs to rise and then have to determine whether they're going to use it. And a lot of times in Atlanta they'll do acetadote just because it's easier, and it's a full course and it solves a lot of problems in their mind. So
don't be so sure you're not going to repeat the acetaminophen level. This guy might have come in 90 minutes after his ingestion. So if you don't, you may want to repeat it in this case, depending on what you find out. And if the next one's 1,000 or 990 or whatever the Canadian cutoff is, you probably will. I think it's around 1,000, if I recall correctly.
That's our 4 hours.
You want to.
Acetaminophen level is repeated and rises, and the LFTs are not. What would you do then?
Continue.
I would still, because again, you don't see LFTs rise until 24 hours, and this guy may be 35 minutes post ingestion, and he's just knocked down from his sedative. So.
I would definitely repeat the acetaminophen level. Part of what, because of Prashant said, you may be early and it may be going up, but you could also be on the downside, on the backside, and it may not clear by the next morning, which means that very slow elimination, probably the LFTs are going to be elevated. There's some problem with liver metabolism. So I would still check it just to make sure.
Well, it's now 6 hours after presentation. They did repeat the acetaminophen level, and it has decreased to 60 micromoles per liter with 9.1 micrograms per milliliter. Patient does have normal LFTs, but now I didn't have a previous pH, but the patient was not the pH was normal before. It's now dropped to 7.15. Bicarb is now dropped to 12. Serum osmolality is 435, calculated is 286, creatinine's increased to 215 millimoles per liter, 2.4 milligrams per deciliter, and glucose is 15. So we now move on. What else could be causing the patient's symptoms? And
We
now,
have great, now we have a lot of stuff to choose from.
so now, what new treatment advice do we have?
I have a question about that last slide. The slide previous to that had a bicarb of 24, and it's now down to 12.
That's correct.
So that was a bicarb, not a PCO2.
It was a bicarb.
Okay.
So the bicarbs drop, the pH is dropped,
And
osmolality.
it's happened pretty quickly, actually. So what was that first set of?
Well, that was when we got the blood work. I'm not sure exactly when it was drawn.
And that would tell us something too, because
Right.
we're looking at the osmolar gap. We're looking at
Right.
very much a potential for toxic alcohol.
Right.
If it's late like this, it takes a while for methanol, and that pretty much rules that out. Ethylene glycol is very much in the differential. Also, looking at the elevated glucose, now we're talking about very, very likely a calcium channel blocker as well. And also that would perfectly explain why we've been having such difficulty with the blood pressure. So I think we'd be looking at a couple of mixed therapies that we might be seriously considering. HIE would be one, of course, and then, of course, the 4-MP antizol. So.
And a renal doc at this point. If it truly is the possibility of a toxic alcohol, their acidosis is sky high. And the time between these labs was how many hours?
6 hours.
It was 6 hours in between those labs?
It looks like it.
It was 6, that's right.
Okay, so it's about 6 hours in between. So in the span of 6 hours, they become tremendously acidotic. And so you need a renal doc. 4-methylpyrazole or fomipizole is definitely going to be indicated. But once you've started to get the acidosis, that means you've got metabolic products that have gotten past the alcohol dehydrogenase enzyme. So you need to dialyze them to clean that stuff up to get that out of the system before it becomes oxalate and therefore calcium oxalate crystals.
Okay. So our treatment advice at this time, we recommended not to give any mucimist based on the repeat acetaminophen level and the liver functions. We did recommend to give a dose of fomipizole, draw the toxic alcohols, consider dialysis if there's elevated levels. Again, recommended multiple dose charcoal for the phenobarb. Transfer, keep in mind this is still a small community hospital. Transfer to a dialysis center, and if it's a suspected calcium channel blocker, give insulin and glucose. Now, this is our next audience question. Testing for toxic alcohols. Now, these are for cases that are not located in your, they're kind of, the formatting all changed. For cases that are not located in your city, what is the general turnaround time for toxic alcohol results? And the numbering, the numbering's all wrong. I don't know what happened to it.
Oh, yeah.
Is
See
there-
if you can hit backspace. Hit back.
That's all.
Yeah.
That's not what it was.
Oh, that's odd. Okay. Y'all, just for the first one that says number 2, pick A. For the one that says number 3, pick B. For the one that says number 4, put C. Number 5, put D. And number 6, put E. If you could do that when you're picking. It's not on. Oh, they do have numbers on there? Well, then just pick the numbers. That'd be easier.
It didn't look like that.
Just indent it.
Yeah, just pick the numbers as to, for healthcare facilities outside your host institution, what is the average time that you expect to get a turnaround?
I mean, it's a hard, sort of a hard question because it depends on the geographical area of your poison center. I mean, you know, depending on how big that is. Your best response. Or what? Yeah, see, it's kind of all over. I mean, at my center, we are all over too. I mean, a lot will be 4 to 12, but I mean, we're the province of Ontario, and if we have ones that are way up in the northern, there's only a few places in the province that will do toxic alcohols, so the blood has to be flown out, then you're possibly looking at 12 to 24, or maybe even greater than 24 hours if it's in a northern nursing station. So my result would be variable as well. So it's 9 hours after presentation. The blood pressure's come a bit. It's 79/53 now. Heart rate's 80. Patient's having poor urine output. Up to now, the patient's received 10 liters of IV fluid, has had 6 amp boluses of sodium bicarbazole and infusion. He's given 2 amps of calcium chloride, a loading dose of omeprazole, single dose activated charcoal, and an insulin drip for hyperglycemia. So another 9 hours have gone by, so we're now at 18 hours after presentation. The patient's fully vented. Blood pressure is still a concern with a mean arterial pressure of 63. Heart rate 75 to 95. High doses of phenylephrine and dopamine and Levophed. Urine output is still remaining poor. Dialysis was started, so the patient's now transferred out in a larger institution. They started it 2 hours ago, and their plan is to do an initial 8-hour run. The ABGs are corrected, pH 7.45, PSO2 of 40, PO2 of 130, and a bicarb of 28. Would you recommend anything further at this time?
How much insulin is he on for his hyperglycemia?
You know, I'm sorry, I don't know how much they were actually.
Okay, the only thing I would, first, if they have an ionized calcium, that would probably be helpful, because sometimes the calcium can be normal. Calcium is an inotrope, so sometimes giving calcium can help your blood pressure no matter what the cause is. The other thing is there's been a lot of talk here about calcium channel blocker overdose as a potential co-ingestion. If that's still sort of in the background, then they probably want to up his dose of insulin to a real, as we heard yesterday, maybe even up to 10 units per, or was it yesterday, 10 units per kilo per hour of insulin to see where that goes.
I did fail to mention that there was some, they did find out, one of the discussion was finding out what else, other medications he had access to. And they did become apparent, but there was no history of any, beta blockers or calcium channel blockers being available to him. So 19 hours after presentation, they finally have initial blood work. The phenobarb levels 51 micromoles per liter, 1.2 milligrams per deciliter. Initial methanol level was 130 millimoles per liter, or 416.5 milligrams per deciliter. Repeat methanol level did decrease. Ethylene glycol levels still pending. They had given 2 doses of omeprazole, pyridoxine, and thiamine, and any new advice at this time. So it's a known methanol.
So we were talking about this among ourselves because I have a lot of questions. So the omeprazole dose doesn't look like it's really being given adequately for somebody that's on dialysis or it's been being dialyzed. They should be receiving.
That's in my next slide.
No, I'm sorry. Sorry. But and then the fact that they became acidotic so quickly.
Right.
And we really wouldn't expect to stay with methanol. But, it could be a mixed ingestion.
Yeah.
Ethylene glycol is still pending. I'd like to know what the acid-base status of the patient is. I guess that was the previous slide. It seems to be doing better with dialysis.
Yeah.
So I think we continue where we were going. Some of the adjuncts you're giving the adjuncts as correctly. Again, I'd like to know some good set of labs and, like Prashant mentioned, calcium.
Right.
Where we're going.
I'd like to add one thing on about the issue of the acidosis from the methanol. I know in micromedics and some of the textbooks it says toxic metabolites may not show up for up to 24 hours after ingestion. I've never been able to find a good source for that, where that actually came from. There was a paper that described several outbreaks, and in those outbreaks it took up to 24 hours for toxic metabolites and methanol to show up, but there's nothing in there about whether or not these people had ethanol on board. So I agree with with what you said about the acidosis may be delayed, but I wouldn't also be surprised if it happened this early, given that some of that data I just can't find where it came from.
there's so much we don't know, obviously, about this patient, but there's, when you look at a lot of the methanol, the large case series of methanol ingestions that they were dealing with in Norway, for example, they had multiple patients that were very critically ill. A lot of those did not present for 12 hours or so. And of course, they were sold methanol, but we don't know if they were mixed with, it was co-ingested with ethanol as well, so time, delaying the metabolism, so we don't really know an awful lot. But the presentation for a 6-hour gap in between there is really so quick. It's really kind of astonishing.
So
I agree.
I'm just going to carry on because we're getting a little bit behind time. So, I'm sorry, you know what? I went the wrong way. Pardon me. So we actually recommend to dialyze till the methanol level is 0, repeat the level 2 hours post to rule out rebound, give the famotidine Q4 during dialysis, also to give leucovorin, 1 milligram per kilo, or maximum dose of 50 milligrams Q4, and get the ethylene glycol level, but it's not going to change. You still need to dialyze the patient. And if the patient does have an ethylene glycol level, it may still require pyridoxine or the thiamine. Day 2, they call this, the patient's now had a grand mal seizure 2 hours ago, was given Ativan 8 milligrams, phenobarbital 500, and then to receive 30 milligrams Q12, still on vasopressors, passing urine now, dialysis continues, the levels methanol levels decreasing quite nicely. Any treatment advice or special consideration regarding the seizures now? Very quickly.
Seizures are seizures. If someone has an acute seizure, you usually treat them with a benzodiazepine unless there's a reason not to. And although hemodialysis is not the probably preferred method of removing phenobarb, some will no doubt get removed. So it'd be interesting to know what his phenobarb level is.
Right.
Yeah, I'd really like to know, I would have been getting serial vital signs and serial blood work.
Right.
We don't have a lot of the puzzle. We don't really know where they are metabolically. They're being dialyzed, which is really helpful, but did we ever get a CPK back? Did we get any? The LFTs were reported as normal.
Right.
Has anything changed as far as any of that goes?
Right. Well, we did recommend that the phenobarbital could be dialyzed off, and they may want to reload the patient with phenobarb post-dialysis. Day 2 follow-up, the patient's awake and alert, no further seizure activity, did get 12 hours of dialysis till the level was 0, decreased need for vasopressors, remaining on a little bit of levofed. And on day 3, the patient was awake and alert following commands, blood pressure 120/80, heart rate 65 to 75, off all pressors, good urine output, extubated and transferred to the medical floor on day 4.
Did she tell us what she took, or?
He,
Did he tell?
no, I didn't, we don't have that. It became too psych-related.
So we were right.
When in doubt, take
But
a
we knew it
history.
was methanol.
Just a quick question.
Thank you, Donna. That was wonderful.
Can I ask just a quick question? I saw the comment of dialyzing until the level 0. What was the turnaround time at your hospital to get?
Oh, now that the hospital, the patient can get it in real, they actually do the levels on site.
Oh, wow.
So it's very timely.
Okay, thank you very much, Donna. And expert panel, thank you too. Our next speaker is Gay Milenchik. She is a third-year SPI. She's a C-SPI at the Rocky Mountain Poison Center. She's an RN, and this is her third year there. Thank you, Gay. And let's come down to the show. Let's just do slideshow. Let's start from the beginning.
But that's okay.
Hi. Thank you for coming, and thank you, panelists. And I'm talking on, I've got the GI blues. So it started out, with a ER nurse calling and the Poison Center stating that a 15-year-old female student was en route to the ER after she was found with an approximate 500 cc pool of emesis. And EMS intubated the patient at the scene. The RN states that the student has ingested a 7% solution, and at this time there's no further information. So the first question would be, what 7% solution was ingested, could possibly be ingested? So go ahead and vote. Okay, so 42% voted A, the camphor, and then, so most of you voted for the camphor, then low at the 3% for the cocaine, and then kind of even at the iodine, and then 11% for the methylene blue.
By chance, are you a fan of Sherlock Holmes, and is that why you had cocaine up there?
I do like Sherlock Holmes.
Yeah, for those of you who don't remember, the 7% Solution was a book and a movie about Sherlock Holmes shooting up cocaine, and it was a 7% solution of cocaine he shot up.
I did learn this. And so, go ahead.
Can we go back a couple slides? I thought our choices were tetrahydrozoline for.
It did change before I sent my so we have changed that. I know, my little teaser slides.
Okay. Trick question.
And so, typically the camphor comes in less than 11%. In the early 1980s, the FDA decreased the camphor to be a limit of less than 11% due to deaths. And, the cocaine that the doctor already brought up. And it typically, oral ingestion is not your typical route that they'd want to do with cocaine. And then iodine, it does come. That would be a high percentage for iodine. Typically it comes in the 2%, but it does come in the 7%, which would be a strong solution. It's caustic and whatnot. The methyl salicylate, typically 30 to 98%. It would be a salicylate toxicity concern. And then the methylene blue, it comes in a 1% solution. It can cause, various and sundry problems, and it can discolor the urine and the stool a bluish color. I think I might have to, okay. So at this point, we did know that the patient drank 8 ounces from a 16-ounce bottle that contains a 7% iodine in an 82% isopropyl alcohol solution. Okay. So, panelists, what would you tell the emergency room nurse at this time?
I think I'd want to know what the patient looks like before I'd want to tell them anything. So I'd want a really good set of, basic metabolic profile, vital signs. Is she intubated and being supported? What's her blood pressure? Is she on any pressors? I'd really want a lot more information before I'd recommend anything.
The next slide does, kind of, we were wondering, but we just know at this point that she's intubated in the field. But we agree that, they wanted to find out what the clinical effects, might be, and get that information. And then what diagnostics, like you were saying, vital signs, the history, current medications, co-adjustants.
Did y'all see the clinical effects? Could you
So
go back?
I'll go back. So it's just the clinical effects that can can happen
Oh, that can.
with the iodine.
Oh, it's not what she was experiencing?
No.
Oh, okay. I'm sorry. Go ahead.
And then the, you know, what information we would like to see, like you were bringing up, you know.
When did we find out about the iodine?
I knew upon that initial call, so we did know on that initial call she was found with the 500 cc emesis. It was an iodine 7% solution, which is that high solution.
How much of that emesis came back up? Because just throwing it through an alcohol calculator, if you assume she's 60 kilograms, just at 8 ounces of isopropyl alcohol, that's 82% solution, that's an isopropyl level of 423.
It is difficult to say. They just said they estimated it to be 500 cc's. So she, you know, drank 8 ounces. It was half gone of a 16-ounce bottle.
Okay.
So that's the information we had.
I think that's, you know, this is important because, I mean, I will be the first one, I'll admit that I put my finger on camphor when I first read this, because this fits actually quite nicely with camphor. Camphor does come, I mean, it doesn't typically come as a 7% solution, but it can come in a lot of liniments and so forth. And you can get products with 7%. And iodine, you know, you got to look at, with any product, what is the vehicle and what are the excipients? And in this case, I mean, the real severe oxidation is the isopropyl alcohol, not the iodine. So that's also a good point.
Okay. So our next audience participation would be, you know, what would GI decontamination is needed? Gastric lavage, activated charcoal, starch. Would you give all of the above or none of the above? And so 68% said E, none of the above. And then 32% said C. And, you know, so, you know, this can be very controversial, and we'll get into this with the panelists also. You know, because if you gastric lavage, you have to take into consideration that it's caustic going down, could be caustic coming up. Activated charcoal can be used, but, you know, it will interfere with a possible need for endoscopy. And the same is with the starch, you know, possible interference with seeing the end result of the endoscopy. And so iodine ingestion, you know, it is caustic to the GI tract. You know, it can stain the mucous membranes brown. The vomitus may be blue if there's any starchy foods present in the stomach. And iodine is readily inactivated by starch and converted to a non-toxic iodide. And typically, you know, iodine is one of the oldest antiseptics, you know, that's been out there, topical antiseptic. And ethanol is used as the solvent in the tincture of iodine, which allows, you know, substantially more concentrated forms of the iodine I2 to be available. Ingestion is less common now because of the change to the antiseptic use from iodine to iodophores. And so panelists, you know, it was in here, I found some information that, you know, for large exposures, you could consider gastric lavage using milk, cornstarch, or the sodium thiosulfate. Activated charcoal does bind to the iodine, although it has not been shown to affect the outcome. So would you recommend any of the gastric lavage, activated charcoal, starch?
Before that, let me just ask, because a couple of us were talking, on initial presentation, did you get the color of the emesis?
I did not get the color.
Okay. I mean, but we know it's iodine, but
right.
In terms of a
they had
differential,
found that the bottle was apparently right there.
I think it'd be, I mean, starch is the traditional treatment for iodine, but with such a high concentration, she's on a, you know, she's intubated. I think it's pretty clear she's going to need to be scoped.
I'm not sure how much the iodine is going to affect being able to visualize anyway, but I think I'd be pretty hesitant to put anything else down that's going to possibly obscure any visualization under endoscopy.
Thank you.
Yeah, I would agree with that. You don't want to mess up the look for the endoscopist or they'll hit you.
And I think Levon is worried about a burner. It's probably not a really good idea either. If you really have a soft tube, I suppose if you were absolutely had to do something, you might try aspirating to see if you can get some contents out. But that's as far as I would go. Again, but though if you've got a esophageal burn or something, you're risking sticking a tube through it and then getting mediastinitis, which is even a worse disease.
Okay, thank you. And so 4 hours post-ingestion, the new information that we have is that she did also ingest the propoxyphene with acetaminophen, and which can cause cardiac arrhythmias and CNS and respiratory depression. She also drank an unknown quantity, and this was unknown quantity of both, of the 5-hour energy drink containing caffeine, which of course can also cause confusion, seizures, tachycardia, hypotension, and metabolic acidosis. Her vital signs are stable, and they had placed an NG tube down and activated charcoal was given. This was prior to us knowing.
Feeding off what was just said, one of my WISE ICU teachers said to us, all of us fellows in training, there are going to be times when you're going to come into a room and everybody's going to be yelling at you, just don't stand there, do something. Being a good doctor is being able to flip that around and say, just don't do something, stand there, figure out what's going on. We don't always have to do stuff, and that's a hard thing for us as healthcare professionals to not intervene, but this person really didn't need activated charcoal. I mean, even with the history you've given, because of the possibilities for burns in the GI tract and the need to scope.
Right. And continued information is she was sedated, she was positive for the propoxyphene, glucose was fine. There was no other labs available, and they did have to transfer her to a tertiary healthcare facility. So at 5 to 6 hours post-ingestion, the patient had arrived at the PICU at the tertiary, hospital. She was in a pretty stable condition. Electrolytes were normal. We did recommend that they get a GI consult. They had done that. And the doctor was asking if they needed to give starch at this point. So would you?
Only if they're going to be making corn muffins.
See, now she's in my domain. She's in my PICU, so now we can control what goes on a little more than what you could before. No, I definitely would not want it. The horse is out of the barn and probably in the next town by now. So.
Okay. So our toxicology recommendations were no need for starch, since she'd already received the activated charcoal, to maintain the adequate hydration, making sure that she's having good urine output, monitor, give her the IV fluids, really looking at the electrolytes for any acidosis, anion gap can decrease in this, and then, H&H because there's concern for the bleeding. And renal failure has been known to happen within 1 to 3 days post-ingestion of iodine. And we wanted her on seizure precautions, not only for the iodine, but for the propoxyphene and for the caffeine also in the 5-hour energy drink. So 8 hours post-ingestion, she's still doing pretty well. And they called and said that GI was preparing to scope the patient at this time. So they're getting ready for that. So the initial endoscopy results, by the endoscopist, it revealed burns throughout, from the mouth to the duodenum, with areas of 3rd-degree burns in the GE junction. The patient was being treated with the H2 blocker famotidine. So significant, almost circumferential burns to this patient. And then the first day post-ingestion, she still remained intubated, having copious amounts of fluids out of the NG, which really concerns for the hypovolemia and shock. Hematocrit's okay. They did get a positive Tylenol level that was not treated. They opted not to. And, the lactate was, she's really not showing any evidence of tissue damage at this point that's, horrific. And there was no anion gap. Her chest x-ray was normal, so no signs of aspiration or, damage to the caustic injury to the lungs.
What's her mental status like?
She was still, at this point, remained intubated, sorry. And that's all.
But is she being sedated for intubation, or?
They didn't say specifically. On the previous call, she was sedated and intubated and vented. And so as far as I know, she was still sedated and vented.
You can never want to assume anything, but the standard of care in a pediatric ICU is continuous intravenous sedation unless you already obtunded, in which case you don't. But you would never just, unless you're trying to extubate them. And it sounds to me with all these burns, they're probably not in an anxious rush to extubate her.
Right. And so the patient, over the clinical course, she continued to improve daily. She did undergo, the healthcare facility opted to do 3 endoscopies on day 1, 3, and 5 with improvement noted. And she was discharged to psychiatry on day 8.
Did you say that she was on an H2 blocker?
She was on famotidine.
Okay, because I don't even know whether it makes a difference with a burn like this, but I figure if you're going to block acid secretion, go big or go home. Use a PPI in a case like this. Don't use an H2 blocker.
Okay.
And just out of curiosity, did her pregnancy test come back?
That was, and I'm sorry I didn't put that in there, but that did come back negative.
No.
Did we ever get an ethanol level on it?
There was not one drawn that I saw.
And what about an EKG, given the propoxyphene?
I know, let me see. Yes, because I think I'd had that on there, that the EKG was normal. I apologize, yes. All right. Thank you so much. Thank you, panelists. Thank you.
Thank you, Gay. That was great. Okay, our next speaker is Adina Sherrock, and she is from the Massachusetts Rhode Island Poison Center. She's been there for 18 years, and she is an RN and a C-SPI. There you go.
So the name of my presentation.
And you can click there or click right there. Click right over there. Right. That way, yes. And I just, yes.
The name of my presentation.
Click right there so it comes up. Oh, I'm sorry. Okay, there you go.
The name of my presentation is Far East Side Story. 2 Cambodians, a 39-year-old female and a 40-year-old male, tried to commit suicide together. The ER doctor who called me said that they ate a Cambodian herbal medicine that looked like a mushroom. So I asked him to email a picture to me of what they ate, and that's a picture of what he emailed to me. And he also said on his initial call that they were both having seizures. So I've worked for 18 years in a poison center, and I'd never seen anything like it.
I would eat that.
So patient X, the female, was afebrile. Her blood pressure was 105 to 125 systolic. Her heart rate was 90 to 130, so she had some tachycardia. Her O2 sat was 100%. Her QRS was 0.80 and QT 0.36. She did not have any EKG changes. And charcoal was given before they called the poison center. We didn't recommend charcoal. Patient Y, the male, he had a temp of 100 degrees Fahrenheit rectal. His blood pressure was 115/68. His heart rate was 62, so he wasn't tachycardic. His respiratory rate was 18. His O2 sat was 99%. He had a QRS of 0.12, but there was no R wave in AVR, which could be, maybe tricyclic. So but before calling the poison center, the ER doctor on his own gave 3 amps of bicarb without any change in the QRS. We didn't recommend that. The QT was 0.356. He had no EKG changes, and he was also given charcoal before the poison center was called. So they were both acidotic. Patient X, the female, had a pH of 7.1, a bicarb of 6, an anion gap of 31, a lactate of 18. Her sodium was 141. Her potassium was normal. Her chloride was 104. Her glucose was 120. BUN 13. Creatinine 1.1. MAG 2.4. On the initial call, the serum osm, methanol, and ethylene glycol levels were all pending. She had an ETOH level of 26 milligrams per deciliter. Her Tylenol and aspirin level were negative. Her LFTs were normal. The serum and urine tox screen were negative, and her white count was 15,000. Patient Y, the male, had a pH of 7.1, a bicarb of 3, an anion gap of 32. They didn't do a lactate on him. They only did one on her because I guess they figured it would be similar. I'm not sure why. His sodium was 138, potassium 3.7, chloride 103, glucose 242, BUN 12, creatinine 1.5. His calcium was normal. The serum osm and methanol and ethylene glycol level were all pending. His ETOH level was 0. His Tylenol and aspirin were both negative. He had normal LFTs, and his urine and serum tox screens were negative. So the ER doctor told me that both patients were having tonic-clonic seizure activity, but they remained fully awake and they weren't post-ictal. They were both severely hyperreflexic. And he said even minor stimulation, such as him just walking into the room, resulted in them becoming more jittery, shaking a lot, and having clonus. So what did they ingest? Audience, please pick your answer. A would be camphor, B would be strychnine, C would be phencyclidine, D, sodium phosphate, or E, none of the above. Oh, so 77% picked 2, strychnine, 10% C, phencyclidine, and 5 was none of the above. 13% is none of the above. Okay. So I'll ask the expert panel, what did they ingest?
First off, if I don't have the luxury of having, even if I did have the picture, which you eventually had emailed to you, so if I have someone telling me I might have a Cambodian-type mushroom, I'm going to be thinking first, what mushrooms might cause an acid-base disturbance, seizure activity, just in, you know, if it were, you know, a mushroom here, and maybe they have the same kind of mushrooms, you know, by mail order, you know, from Cambodia. And so I'm probably initially thinking, you know, maybe an INH type containing mushrooms, MMH, or, you know, one of those, just in my initial differential. And then thinking, you know, do I need to be thinking about, you know, standard seizure treatment, or should I look at, pyridoxine and things like that? I don't know that I'm jumping all over this, and I don't know that strychnine would have been the first thing that I would have thought of. I would have thought a mushroom here, and then go from there. And then obviously a picture would be helpful, but in this case, Prashant and I were just talking, we probably would eat that stuff too. It looked, didn't look that bad. It actually looks like a scallop. I don't know that, I mean, I might have eaten that and wait for the seizures later, but I probably would be thinking, maybe a mushroom here, and then, trying to, go through my step-by-step process to try to figure out what might be going on. I don't know that strychnine and mushroom initially came to mind when I was thinking about this case.
Well, I had the advantage in pharmacy school. One of the things we did way back when I was in pharmacy school was we injected mice with strychnine. And it was pretty amazing because the mouse was fully aware, fully conscious the whole time, and any sort of stimulus just snapping your finger would trigger really dramatic tonic-clonic seizures. And there really aren't, the differential for botanicals causing seizures is pretty broad. And it would have been nice to have from that picture something for scale, because we don't know if it's like peyote button size or if it's pretty small, I have no idea. But the fact that they had a normal sensorium after a seizure, it pretty much is a slam dunk that it would be strychnine. But that's only because I had the luxury of having had that demonstration. It was something I would never forget.
I have a newfound respect for my colleague Fred here, because I'm very poor at assessing mice level of consciousness. So I'm going to consult you next time I have a sick mouse in my hospital. I agree with Fred. I think there's very few, if any, things cause this type of activity with an intact sensorium, so no postictal period. And even though it looks like a mushroom, the contamination of other things with strychnine, I mean, it's pretty common, and we see it with, even with heroin and things as a contaminant, or actually it's an adulterant, it's not a contaminant, it's put in intentionally. So again, I think you got to focus on the clinical picture here and not necessarily on what this thing looked like because of that. There are other things that can do this. I mean, people do get myoclonus, myoclonic jerks from other things. So hypocalcemia, for example, can cause this, although it typically is not this severe. You don't usually give yourself a bicarb of 3 from a low calcium. And there may be other things like tetanus, potentially. Gyromitra, the monomethyl hydrazine containing mushroom, again, the kicker here is that would cause profound obtundation, like INH. So I think for me, strychnine was pretty much the only thing on the list.
Or cyclotoxin, something like cyclotoxin. That's rapid onset of seizures, but again, they don't have a normal level of consciousness in the postictal.
Okay. So the differential diagnosis, are there any more comments? So tetanus, epilepsy, hypocalcemic tetany, dystonic drug reactions, or strychnine. And the key to recognizing the strychnine poisoning, like you said, was the observation of convulsive activity in the awake patient, and there was no postictal phase. So what they ingested is Strychnos nux vomica. You can see the picture on the bottom. And Strychnos nux vomica is the name of a tree native to Southeast Asia. And on the left, that's a picture of the berries of the tree. And the seeds are removed from the ripened berries of the tree, and they're dried in the sun. They're also known as slang nuts. They're a traditional Cambodian remedy. And in Cambodia, the slang nuts are wrapped in tobacco and leaves, and they're held against the buccal mucosa as a mild stimulant and also to relieve abdominal discomfort. And it appears to be a common practice among older Cambodians, although it has no known medicinal value in the United States. And the dried seeds contain both strychnine and brucine, a less potent alkaloid. The seeds of the Strychnos nux vomica contain 1.1 to 1.4% of strychnine, which is a colorless and bitter tasting chemical. And strychnine is a competitive antagonist of glycine. So glycine is an inhibitory neurotransmitter in the spinal cord. And strychnine blocks glycine's inhibitory action, so the disinhibited motor neuron fires continuously. And the result is powerful, uncontrollable muscle contractions. It has a rapid onset within 15 to 20 minutes after ingestion. You get recurrent violent convulsions with an intact sensorium, and stimulation can provoke or worsen the spasms. And you get opisthotonus, which is that arc shape. His back is like in an arc. And also you get this strange facial expression, facial trismus and risus sardonicus. And the tetanic contraction of the skeletal muscle produces rigidity and tachycardia and hyperthermia. And some patients could develop a severe lactic acidosis from the uncontrolled muscle activity. And involvement of the thoracic and diaphragmatic musculature leads to respiratory paralysis, which is the most common cause of death in strychnine toxicity. There's no quick routine test for clinical decision making, but it is found in tissue at amounts as low as 0.01 parts per million, and it's resistant to postmortem putrefaction. And the fatal blood concentration is about 0.5 to 61 milligrams per liter, but levels do not correlate with clinical progression. The volume of distribution is about 13 liters per kilogram, and it's rapidly absorbed, and the first order elimination half-life is 10 to 16 hours. So just ask the expert panel, how should this case be managed?
Well, I would start off with a truckload of benzodiazepines, whatever you need to calm down the muscle activity. If you need to intubate them to protect their airway, to stop the muscle activity, so be it. So start off with a truckload of benzodiazepines. I would probably start with lorazepam, and if I'm not having good success with that, I'd go to bigger doses, or with big doses of lorazepam, I'd add midazolam onto that. And if after, what I would consider a nice hefty slug of those, if that's not working, then you have to paralyze them. Of course, you're also looking at their core temperature, making sure that they're not getting hyperthermic to the point where they're going to start causing other problems, following LFTs, following the labs that you have there, and also getting a CPK to find out how much muscle they've destroyed.
I wanted to add one thing to what Dr. Bote said, and that is if you do decide to intubate this patient, they don't get put on a rate of 14 and a tidal volume of 500 unless you actually want to kill them, because this is a patient who already has a severe metabolic acidosis and may well be compensated by breathing quickly. And so we've seen this time and time again with well-meaning physicians with someone who sees Kussmaul breathing and a salicylate overdose as being respiratory distress. And we've had patients die because they acutely drop their pH. I think what we have to, these patients, you may want to even not paralyze them to intubate them, keep them breathing spontaneously, because remember, when you intubate somebody, you give them a paralytic, there's a period of apnea. And their PCO2 can climb fairly rapidly, and their pH can drop fairly precipitously as well. Other than that, I absolutely agree with the management.
Anything else?
No, if we do manage aggressively with the truckload or two of benzos, usually the prognosis is pretty decent, so there's not much, magical that we have to do here.
I would throw out one thing, and that would be what if any role might baclofen play in the role of strychnine poisoning? Because we use this for spina bifida spasticity, which is presumably spinally mediated. I don't know that I would do it. I just throw it out as a sort of theoretical idea.
I'd follow the Joshi procedure once it gets published and accepted.
Okay. So that's exactly what we did. We gave them high-dose benzos because those are the mainstay for controlling the muscle activity. And what benzodiazepine does your institution use for controlling muscle activity? A, clonazepam, B, diazepam, C, lorazepam, D, midazolam, or E, none of the above. So, number 3, lorazepam, 51% of you picked, which is what we generally recommend in our poison center. Clonazepam, 3% picked, diazepam, 23%, and midazolam, 21%, and none of the above was 3%.
I want to know what the none of the above people use.
I can tell you, when I'm a veterinarian, high-dose benzos don't work in dogs at all for strychnine and tremors. So we use actually methacarbamol, and we put them on a propofol drip.
Oh, good. That's really cool.
So I guess I don't.
Has your experience with strychnine been with like coyote bait kind of
Yeah.
thing? Interesting.
It's also commonly used in the northwestern United States as a malicious poisoning for dogs.
Wow.
So all the symptoms in acidosis resolved after the benzos were given, and our patients did not need intubation or anything. They were transferred, though, to a tertiary care center. They did extremely well, and their tox screens were positive for strychnine. So we did determine that it was the Nux vomica seed. And I just want to give a special thanks to Becca Sumner for her help with the slides.
I hope you wrote that up to report that. That was pretty interesting. Did you want to submit that?
Can I just add one thing before you go on? I grieve to say this. This is representative of the current state of affairs in this country, but if you actually Google slang nuts, you will find vernacular terms for testicles. Actually, when you it'll return as a search. So you really have to look. Actually, in Gold Franks you can find it, but I thought I could find more on the internet. It was very difficult.
Thank you, Adina. Thank you, Adina. You did a wonderful job. Okay, our final presenter is Jean Ragoon. In 2000, he started with the Miami Poison Center. In 2003, he went to work at Georgia. That's where he works today. He is an MD, third generation MD, and he is a C-SPI. Please welcome Sean.
And now I get to rub in that we are the East Coast champs of this quiz bowl, so that was really good. Go Yankees. You know, when we discussed about doing this topic, this was prior to the incident in Japan. Dr. Kazi, Ziad Kazi from the Atlanta Poison Center or Georgia Poison Center, like most of the physicians that are at our group and toxicologists, PharmD toxicologists, play active roles in surveillance, mass casualty medicine, well, you know, whether it be radiologic or biological. And thus, they are, and we are developing programs that will enable the SPIs to be part of those procedures and protocols. Because obviously we're blessed to have 15 toxicologists. We're blessed to have a large C-SPI group as well. I think almost everybody is a certified poison specialist. And with the fact that the CDC is in our backyard, you know, we are the public health capital of the world. And even though most of the data out there might not have us as a target in the sense of a bioterrorism or a nuclear event, you would assume that we do because of the CDC's capabilities in testing and classified information, which was very hard to try to figure out in the first place. And I kept being told by various government officials, we just can't tell you that information. So, you know, we were talking, the title of my, where is it?
Should be at the bottom. You see it on the bottom? Let's see, there it's toxic trash, so,
Okay.
no, just, you'll have to do this, and then do that, and then we'll come over here. And whatnot.
Okay, so as the title, you could assume what we're headed here is, you know, toxic trash. This is not rubbish. Once again, this in its inception was going to be about the several, you know, cases that we get a year where, you know, nuclear waste or nuclear material shows up at these sites, and you know, we'll set off alarms, and we'll see here. But then, you know, Japan occurred, and writing this PowerPoint became just a snowball of, my goodness, how do I cover all this other stuff now that we have Japan and the interest of radioactive material. And thankfully, Dr. Lopez had helped me narrow it down and keep my attention deficit disorder focused on this, along with Dr. Slattery. So basically here, I'd like to start with a quote from Albert Einstein, where he said, "The world is a dangerous place, not because of those who do evil, but because of those who look on and do nothing." And Socrates stated that, you know, to move the world, we must first move ourselves. So when I do this PowerPoint, I want to keep, you know, all of us keep that in mind. You know, it's going to take a collective effort, you know, to be able to respond to situations like this. And I think from a poison specialist standpoint, you know, it's the time now to start taking advantage of the different things and training courses that we have available to us for nuclear, radiation, terroristic events in the event that something should happen, because as we all know, we're going to get called, and we're going to get called a lot, and it's, you know, it might inundate the system, but I don't think there's anybody in any other agency like, and this might be just because I love the Poison Center, I love what we do, you know, I truly believe that poison specialists, toxicologists are going to be able to handle any type of event and handle it well. So back to our case, this at 22:46 on a Monday evening, our regional poison center received a call from a concerned 61-year-old male. Caller stated he works at an industrial recycling plant and that he had been exposed to contaminated containers that contained radioactive material. The spy had noted that, you know, probed more about the question about how does she know it's radioactive, so on and so forth. And the driver, you know, said, I'm a little bit more meticulous than other drivers, you know, I'm a little more curious. So before going on going through the scale where they weigh the 18-wheeler and check it for any type of radioactive material, which I found pretty interesting that they all do this in these plants. He had noticed that there were several containers. These containers were lead containers, and when he opened up it was a wood carton, opened it up, saw the lead containers, and then also noticed the universal signs for radiation or ionizing radiation. This, you know, very articulate, probably very educated truck driver knew you know, that he had just hauled this 3.5 hours from another site, and his level of anxiety justly had jumped pretty quickly, you know, and was looking for us to be the anxiolytic there and try to reassure him, because he was being told by everybody at his plant, you know, don't worry about it, it's nothing, and he's obviously stating, no, I mean, it has radioactive shields on it that are stating that we're hauling this with these radioactive logos. So when inspecting the load, he saw the lead containers to be recycled. Two of the containers had the radiation logos on them. Caller noted that he contacted his boss, his employer, or the shift boss, who showed up with a Geiger counter, you know, quote unquote, and that the Geiger counter, when he asked what it read, just said 6,400. So he's trying to give a really detailed history as much as possible to our poison specialist in order for us to, you know, give an adequate consultation. And events like this, not just for specific, you know, use of antidotes, we also have, Dr. Lopez has devised a protocol that in the event that something strange or something that's, you know, not typical for some of the poison specialists, you know, some of our poison specialists have been working for excess of 30 years, you know, handling calls. And obviously, to me, I'm very astute to them. When they say that's something's wrong about that, my ears pop up, and I, you know, because it makes me very nervous, and I want to know as well. So there's this protocol to contact our toxicologist to just, even if it's just a discussion. So the exposure occurred had occurred at 8:30 in the morning. So he called us at 2200. So you know, we have to keep this in mind. Caller stated that he hadn't had any other symptoms for the last 14 hours, or he remained asymptomatic throughout this time. His concern that he was exposed to radiation and nothing was done about it, which is an obvious concern that I would have as well, you know. And he was told that he would be all right and just to go back to work. The shipment, just to note, was declined by the company. It was more so because of this gentleman made an issue of it. I actually physically spoke to this gentleman last week, and from what he was explaining to me, his account is that if he didn't say anything, because he was working at this plant for you know, excess of 10 years, that the shipment would have actually been accepted. But because he did make an issue of it, you know, OSHA policies went involved, and they declined the shipment and sent it, quote unquote, back, and he didn't know where it went. So the healthcare facility report, you know, being exposed to radiation, the recommendations were to be evaluated, given this history, given the unknowns. The 61-year-old male presented to the emergency department asymptomatic. He was hemodynamically stable. His mental status was alert and oriented ×4. The emergency room nurse and the emergency room physician, when they were calling to report that he had arrived, had wanted to know what to do from here, how to proceed, and what our policies were, and you know, the caveats that they should know about. I wanted to note that the nurse had stated that while the patient was at home, he had removed his clothing without being told by anybody. He was telling me that he actually looked online. So he was going off of blogs for his information. And this is prior to calling us as well, that he had gone home, showered off, and burned his clothing. So, you know, he thought that that was the appropriate thing to do. The patient stated that he burned his clothes outdoors, and that, you know, that he thought that was the right thing to do. So the first question we have here is, do you know your institution's radiation safety protocol, the officer or the protocol? And obviously the answers are yes, no, or what is a radiation safety protection officer? How do we do this?
This is for the audience.
Yeah.
Okay. You're good. You can hit it.
Which one should I enter right? Okay, great. So when you look at the 16% that, yeah, when you look at 16%, what is a radiation safety officer or protection officer. Yes, you know your institution's officer and assuming protocol as well. The 44% that do not know, do you have an idea of how you can find out who that person is? Are you familiar with the hospital's protocols, or is there a hospital handbook? Because sometimes the hospital handbook will have a section for mass casualty events and then subsetting it for radiation or something like that.
Okay, before moving on, this brings up a very important point, the difference between irradiation and contamination.
Mm-hmm.
This guy, from the history that's been given, there's no history that he's actually been contaminated.
Right.
He may or may not have been irradiated. It depends on what was between him and the radioactive cargo. So the first thing is irradiation versus contamination. If he hasn't gotten any of this on him, he does not need to be decontaminated. If he was contaminated, then yes, the appropriate thing was remove your clothes, get a shower, shower the stuff off. One of the worst things you could do is, if you're contaminated, is to burn radioactive clothes. Radioactive contamination on you is a bad thing. Radioactive contamination in you is even worse. And that would make it really interesting to see how the feds or whoever would model the burning of radioactive clothes to see where it all disperses. Because if this is in a residential area and he burns that outside and there's smoke going all over the place and it truly did have radioactive contamination, oh boy, you're going to have a real big problem. Yeah, you're going to have a nightmare right there.
Yeah. So
it sounds like this guy may have been exposed to radiation or may not, if there was shielding and there's enough distance between him, but it doesn't sound like he was contaminated.
And that's why I felt that it was important to point out that, you know, one, his logic of why he did it, you know, and two is the fact that this shows us, and I'm sure every poison specialist in the audience knows, that this is exactly how it happens. They either look on the internet, they find something, they follow suit, and then they call us, you know, after the fact. You know, true to form, was he irradiated, or, you know, was it exposure, you know, what level of exposure was it? But I think it's also important to note that our protocol is devised because we cannot trust the public, we cannot trust his history, he's very nervous, there could be things he's missing, and we don't want to miss anything. And we're confident that the hospitals in our state have protocols which they follow because of prior calls, you know, even if it was somebody dealing with radioactive soil for testing for carbon dating.
One other quick point, though, is you've got a patient. I don't know, even after Fukushima, I don't know that the Poison Center would have been first, the first place someone would have turned to. It clearly demonstrates that with information on the internet and blogs, as you were talking about, it would seem natural that a person would go there because it's, number one, quick access. But I think we need to prepare ourselves as poison centers to be able to handle these type of calls, because the calls are going to come to us. It's just that in a particular case like this, you've got someone who didn't have anywhere else to turn to, and we all know what other toxic trash is on the internet, and it doesn't surprise me that he tried to do the right thing and he did steps A, B, and C, but we need to be prepared as an organization to be able to be ready to answer these type of calls.
And radiation is a poison, so why not call the poison center? It's like food poisoning, it could be infectious disease just as much as it, is a poison center issue for a lot of poison centers here. Okay, so for the expert panel, several things. Can you briefly describe your protocol for radiation exposure?
Can I say something real quick? I think we might have missed a slide. You had a slide where you contacted the radiation safety officer as per your protocol, and that's why we had the audience slide, because we thought it was really important to get people, at least the SPIs, to be aware Do you have a radiation protocol? Do you know who your institutions, we call ours our radiation protection officer, but Sean, they call him the radiation safety officer, just so that we just wanted to get that terminology out so that people could go back to their centers and say, well, I need to find out who this is. Who am I supposed to be contacting when we get these type of exposures? I'm in a hospital, so mine was pretty easy to find. But, you know, if you're separate from a hospital or if you're with a university system, it could be somebody different. It could be somebody with part of security. But anyway, if y'all could address all that.
Well, at least in our center, it may not be as important to know the person or the individual. In order to try to answer this question for our spies, within our own intranet, we have documents located in our intranet that describe the who, what, and wheres of what we expect our specialists to know. So even if I may not know that it's, you know, Charlotte Clark or our radiologist, I think our specialists need the tools to be able and the documents to be able to go to, you know, and be able to locate that information. And we have protocols embedded within our own system for the spies to take. And we kind of cheated a little on this in that, of course, in 1992, our poison center, our city was awarded the Olympics. And so in 1992, as a center, we already were doing a lot of disaster planning and preparedness. And so we kind of had a head start on the game of preparedness. And so even back then, we had documents in place that we knew we would be able to direct our poison specialists to go to, because with turnover and without an incident happening every week, we wanted to make sure that we had information available. So for us, at least, it was a matter of making sure we had documents within our protocol books and documents within our own intranet, so whether you were at home teleworking, you had the ability to go online within our system to look for these papers.
And then we did have a bomb explode. I mean, you know, at the Olympics, in the Olympic Park.
For the Iowa Poison Center, we're a little bit different in the fact that we're a separate entity. We're a separate non-for-profit organization. And so we don't have a radiation safety officer per se. We are affiliated with one of the major hospitals. But what we actually do is when something like this happens, we get a hold of the Bureau of Radiological Health through our State Department of Public Health. And they've always been very helpful as the perfect resource to go to. And if the person's actually in a healthcare facility, then of course we recommend to the healthcare facility that you need to get a hold of your radiation protection officer there. We created a set of radiation protocols and guidelines, both for general radiation and for the antidotes, probably 3-4 years ago through help of preparedness funding. And so we've actually had that in our center for a while. Also through our preparedness funding, we've had ongoing continuing education, and that's one thing that actually gets covered every year with our continuing education is basic radiation principles of irradiation versus contamination, who you need to call, the principles of time, distance, and shielding, the high points. So that way our staff is fairly well versed in that.
I don't really have much to add to this. I think Ed made probably the most important point right off the bat, and we want to get more information, but it does sound like this guy was irradiated as opposed to being contaminated. If he were cleaning them out, that would be a totally different animal. We'd have to worry about you know, all the contamination issues, and you know, he shows up in the ER, what did he do with his clothes? Even the water that he showered with would have been a potential issue. But since it sounds like he was just looking at containers that had held radioactive material, it's unlikely he himself was, it's possible he was radiated himself, but not contaminated. We're at a hospital, we would have contacted our RSO, our radiation safety officer. Probably just as big or a bigger issue is what's going on, what happened to those containers.
Somebody needs to follow, the state is going to want to know what's happening to us. Obviously, once the specialist codes it, it's a radiation possible exposure, that's going to trigger an anomaly for the surveillance team. They're going to get a call from whoever happens to be doing surveillance that night to find out what more information is being done. The CDC is definitely interested in these cases, these exposures. They're going to want to really know as much as possible about this and where that shipment is. So I see some big fines and some big problems for the company that was doing this, as well as whoever was transporting it. They're trying to recycle leads. You can sell batteries for their lead content, and it sounds like the recycling plant probably would have recycled those materials even knowing that they were contaminated. You don't even know, but I think there would have been a lot of fallout from that.
Yeah. Feeding off of what Fred just said, do you know, was any interstate transport involved in this? Because that gets very interesting. There's actually a case back in 1997 where it was the same thing. It was garbage that had radioactive material in it, and it went back and forth between 2 different states.
Yeah, this made one trip, but it was on an interstate. And this was an oversight. Keep in mind, we know the outcomes. We know the results from this testing. We know the company. We had a very detailed report of what was inside the containers, why the containers were being shipped, based on the safety officer at the Department of Human Resources Nuclear Response Team. So we have those answers, but for what servicing the purpose here, we're not giving too much away. If you do have any questions, we actually have all of that data. When they checked him with the Geiger-Muller counter, it was negative. I'm not sure. Let me just go ahead real quick. Yeah. So when we use the Andrews curve to determine if his level of exposure based on his white blood cell count, his lymphocyte count, it was within normal range. So as a poison specialist, these are something, with these protocols that are involved, like our protocol specifically puts the Andrews curve and chart inside the protocol. It also shows the different pictures of Geiger counters, for example here, so that the poison specialist is very familiar on not only what they're explaining and recommending based on what the toxicologist is asking, or in the event that we have to say, do this first, so that when we talk to the toxicologist, we either have the answer or, are prepared for that situation. So, this gentleman, in order to determine if he was irradiated or not, we went the full distance. We felt that, in cases of preparedness, in 2004, Dr. Robert Geller had secured a grant that said, with all of this Homeland Defense money that went around to all of these hospitals in the state of Georgia, why don't we go around and see how everybody is using it, where is it stored? And I physically went with him, and I can't tell you how many times they didn't know where the key was. The stuff was broken. Nobody knew how to use this stuff. So, we have a lot of obstacles that, in the sense of preparedness, how we can help set these situations up when they occur, give the proper consultations, have the toxicologist speak. So, there's estimated 16 tons of missing radioactive material. We all know it's urban legend. I spoke to one of the military gentlemen that it's urban legend that the Russians developed suitcase bombs and that they're missing, but it is certainly not urban legend that there are, pharmaceutical grade and military grade material that's just missing. And with that being said, if anything, is a justification why we need protocols, why we need specialists, poison specialists need to be trained in radiation. And Dr. Lopez can tell you what he has made available to us, which is incredible, to help, to be paid to go to these things, to find the time for the scheduling. Do you want to tell them a little bit about our programs?
Yeah, just quickly, because I know we're running short on time, and sort of what Ed was saying, that we are fortunate that we have a number of programs that we offer in conjunction with the CDC, since our toxicologists are affiliated with both us and the CDC, but we've got blast injury classes, we've got AHLS classes, we've got radiation classes. There are a number of things that we'll be able to offer, and we tell our spies and encourage our spies to attend these sessions. Not all of them in Atlanta. We'll pay for our specialists to drive down to South Georgia or Oak Ridge to attend these classes, so we're kind of fortunate in that sense. But we probably have 5 or 6 different type of classes that our spies can go to, and we expect them to go to because it's part of their evaluation. It's part of their yearly evaluation that they're up to date on these classes and they're certified in this or they're in attendance of that. So we have that as an expectation.
And this critical thinking is just that. It's a poison specialist critical thinking. It increases your curve on that because a toxicologist may be very well versed in anything radiation toxicology wise. Or they may not, or how it is, but it's important for them when they're at home, we're giving them a third-person history on a possible cataclysmic event that possibly can turn into a mass casualty event, and therefore we understand that it's important for our learning curve to increase for the critical thinking aspect in order to give the proper information to them to get the proper consultation, put in motion.
To follow up on what Gaylord said, it'd be really great if we actually had the money and the time to be able to send our specialists to that, but being out in the middle of Iowa, we do all that training internally, not anywhere near as extensive as what you guys have, but we're sort of left up to our own to be able to do it.
Well, possibly we could start looking at web-based webinars.
That would be great.
And training that way. And we don't ALHS. I remember when I was one of the first classes, and going to that class, going and seeing her, and that's great for the pressing of the flesh, for handshakes and stuff. But this can all be done on. I'm not sure how many people are raising their hand did the webinar for radiation. I mean, it was an excellent presentation, and things like that are, making that accessible to your spies,
With regard to you and Dr. Geller going around to find radiation instrumentation, I wish you would have come to my place. My Geiger counter is underneath my desk.
That's awesome.
I do have a question for the expert panel. If this call had come into your spies, would you want them to contact the Tox on Call people immediately? Okay. Just wanted to make sure we're all on the same page there.
Would you consider mobilizing all of your toxicologists in the event that it was a mass casualty event?
Yes, definitely. Given that there's only one toxicologist, the answer is definitely yes.
Yeah.
That's
Well, we're currently out of time. I wanted to thank you, Sean,
Sure.
and I want to give a big hand to our expert panelists. Thank you very much. And thank y'all very much for coming.
Oh, and one other thing, if you, there is a program that you can type in your zip code and it will tell you how close you are to the closest nuclear plant. And I hate to say this, we actually took every single poison center in the United States zip code and put it into this program. And Arizona is 47 miles away from and their oldest reactor is 22 years old. Connecticut is 43 miles away with a 35-year-old reactor. DC is 49 miles. Florida is 21 miles. Illinois is 47. And this is just within the 50-mile range. Maryland is 37, Massachusetts 37, Missouri 28. And if that event affects your poison center, you can only imagine, how we're going to, handle this type of situation.
Thank
I have
you.
the list for you guys if you want to see it.